there is of patients with non-Hodgkin's lymphoma who unfortunately either do not respond to frontline therapy or progress very early thereafter within the first 12 months of receiving standard treatment, which is usually the regimen R-CHOP. And these patients, unfortunately, have extremely poor survival of less than 12 months. And the standard of care for these individuals is to give them a second-line salvage regimen, and if their disease is responsive, take them to an autologous stem cell transplantation. But unfortunately, less than 40% of those patients will have chemotherapy-sensitive disease, and another 10% will be unable to receive autologous stem cell transplantation due to other reasons, usually performance status or poor organ function. So CAR T cells and Tisagenlecleucel in particular has demonstrated efficacy in patients with relapse and progressive B-cell non-Hodgkin's lymphomas in patients who have relapsed after second and third line therapy. So the hypothesis was, as we move this up earlier into the treatment course of this high-risk group of patients, that it would result in improved event-free survival for this high-risk patient population. So this was an international phase 3 trial, which randomized patients to a treatment strategy with Tisagenlecleucel following lymphodepleting chemotherapy, or they were randomized to the standard of care arm, which was second-line salvage chemotherapy, and in chemotherapy-sensitive patients, followed by autologous stem cell transplantation. Patients are randomized in a one-to-one fashion and were stratified based upon the time that their relapse occurred, be it within primary refractory or less than 6 months from first-line therapy, or between 6 and 12 months from first-line therapy. They were also based upon IPI score, and they were also based upon the region where they were treated, being in a U.S. center or a non-U.S. center. The primary endpoint was event-free survival, which was determined at 12 weeks from time of randomization, unless the event was death, which was considered an event before the 12-week mark. The key finding was that in this situation trial, the event survival for both groups were identical, and so that tisa-cel was not superior to standard of care of second-line therapy and hopefully autologous stem cell transplantation. We were extremely disappointed and actually surprised about the results, but it did lead us go back to say, well, why were factors that may have prevented the tisa-cel arm from being better than the standard of care arm? And some of the factors that we determined were that on this trial, there was a delay in the infusion of tisa-cel on the tisa-cel arm. And so it took on average of 52 days from the time that the patients underwent leukapheresis to the infusion of the cells. This is a relatively long period of time. And there was a number of logistical and clinical reasons for this delay. But in that period of time, it is our hypothesis that the disease progressed extensively, and that it did not permit the tisa-cel to have its full efficacy. We also looked at the way that we defined event-free survival, and it made this choosing 12-week mark rather than an earlier mark, because there are some patients who had progressive disease during this period of time, which would have been considered an event. We also looked at factors that maybe we're using a lymphodepleting chemotherapy regimen, which is not intense enough to provide adequate disease control as compared to some other trials which use CAR T cells. So where we think these are important observations in as to how to design future CAR T cell trials. And It was important for us to report these results because that's why we do phase 3 trials, because we need to, you can assume and you can anticipate as one expected result, but until you do the trial and you do it in a certain way, you won't know those results. So I think that these results can be used in the design of future trials, that when looking at specifically very aggressive lymphoma populations, that we believe that the earlier administration of CAR T cells is a key feature, and that adequate control, either through a more aggressive lymphodepleting chemotherapy or very aggressive bridging therapies, is important. And we still believe that there is a potential important role for CAR T cells in this patient population. So we're hoping that these results will be incorporated in the design of future trials for this patient population and for other aggressive lymphoma populations.